Go.
For this final project, I chose essays prompt 1 and 2. I'm going to go ahead and read essay prompt 1, and then I'm going to go into explaining it. So essay prompt 1 was walk me through all the steps of depolarization and muscle contraction within the heart muscle. Be sure to address the conduction systems, how we spread signal across the heart, and how we actually exert force, as well as heart failure within HFrEF, HFpEF, and how we may see this within imaging modalities. So to begin with, I'm going to talk about the difference in depolarization in smooth muscle and the depolarization in cardiac muscle. So I'm going to have in pink smooth muscle, and I'm going to have in purple the cardiac. So to start, you have for smooth muscle, you have thresholds of resting membrane potential of negative 70 millivolts. You're going to have your first threshold at negative 55 millivolts, and then you're going to have another threshold at positive 40 millivolts. So your resting membrane potential, you're going to typically stay right around it. Not perfect, but close enough to it. That's where your cell is going to be with this charge. Now, when you receive a stimulus and you want to have muscular contraction within smooth muscle, you're going to receive a stimulus. That stimulus is going to cause this to slowly creep up to negative 55. Once that threshold has been achieved of negative 55 millivolts, sodium is going to rush into the cell. Now this is going to raise the charge of the cell because sodium is a positively charged ion. So Na goes into the cell. Once positive 40 millivolts has been achieved, sodium channels are going to be shut off. Potassium channels are now going to turn on. So potassium is typically inside of the cell. Now it's going to be rushed out of the cell. It's going to be moving across its concentration gradient by opening up potassium channels. Sodium is typically outside of the cell, so it wants to move in. That's why we have the influx of charge into the cell. Now, potassium is also a positively charged ion. That's why we're going to see a decrease in charge. Now, it's not going to be this rounded, it's actually going to be more straight down, but I'm just bad at drawing. So, once you have reached here, you're going to have to go into your refractory period. Now, your refractory period is also called your sodium-potassium pump. This is where, with the cell, potassium is now out of the cell, and sodium is inside of the cell. You want that to change. You want it to be able to reset to the next time of having to do all of this, where sodium has to be outside of the cell and potassium has to be inside the cell. So to maintain an inside charge of negative 70, you're going to pump 3 sodium out for every 2 potassium in. That's a 2. That, because they're both positively charged ions, that's going to allow this cell to be net negative charge around negative 70. So that is smooth muscle. That is exactly how you would go and do depolarization for a smooth muscle electrically. The difference for cardiac is you have 4 different stages. So you have phase 4, phase 0, phase 1, phase 2, phase 3, which goes down, and then phase 4 again. So 4, 0, 1, 2, 3, and 4 again. Phase 4 is your resting membrane potential. At phase 0 is going to be very similar to smooth muscle. You're going to have sodium rush into the cell, which is going to raise the charge. Now, once it is reached here, sodium channels are going to shut off. At phase 1, similar to this, so with smooth muscle, you're going to have potassium channels now open. That is going to cause potassium to slowly go out of the cell. Now, at phase 2, that's where calcium comes into play. Calcium is going to now rush into the cell slowly. So potassium's going out, but calcium's coming back in. That's why this kind of plateaus, because you're both having positive going out and in. At phase 3, that is where calcium channels slow and potassium channels exceed it. So that's why you're going to drop even more, because now more potassium is going out of the cell than calcium coming into the cell. So although you're having positive coming in, you're having so much more positive going out to where the charge is going to just plummet. So then you're going to go back to your resting membrane potential, channels are going to close, and you're just going to rest until you have another stimulus. That's the main differences between cardiac depolarization and smooth muscle depolarization. Now, why is this important? Well, both are going to act in a very similar way. And I'm going to go and explain this through doing a whale diagram. That's terrible, man. Boom. Still terrible, but okay, so that electrical current is going to travel across the motor end plate. And I'm actually going to draw this a little bit better. So this. So it's going to travel across this motor end plate. It's going to reach the T-tubule. The T-tubule is going to allow that signal to dive deep down into the cell. So it's going to be able to travel down. These are calcium sensing feet. These feet are going to sense that there's been a change, and they're going to tell the sarcoplasmic reticulum to now release calcium into the cell. Once calcium has been released into the cell, it's going to find these three things that are attached to tropomyosin and actin and myosin. You have the major three things that are going to be involved here. So the best way I want to draw this is like here and this, and then I'm going to grab a second marker. Marker. Okay, so in brown, that is myosin. Tropomyosin is pink, and actin's going to be purple. So these three circles here, those are going to be troponin C, T, and I. So troponin T is attached to tropomyosin. That is attaching it together. T and I is inhibiting. So T and I and T and I and actin are, you can almost believe that they're intertwined. T and I is going to inhibit myosin from binding to actin. T and C, that is the one that you're waiting for to bind with calcium. So once T and C has binded with calcium, it's going to flip out of the way. So T and I and T and C are both going to flip out of the way, now exposing actin. Once actin has been exposed, myosin is going to see that and it's going to grab onto it. So now grabbing onto actin with myosin, that's going to create a cross-bridge cycle. So cross-bridge cycle, it's explained how I remember it, it's almost going to look like this with a ratchet. With the depolarization, or the removal of phosphate groups and the addition of phosphate groups, you're going to allow this to ratchet together. So myosin and actin is going to have one cock and two cocks. It's going to completely ratchet together. That is how a muscle contraction occurs, by this. So they're very important proteins. So boom, boom, boom. So the reason that this is important and also different within cardiac cells and smooth muscle cells is for each one of those diagrams here, for a smooth muscle, you need a singular electrical current to stimulate each one. With cardiac tissue and cardiac cells, you have these things called intercalated discs. So I'm just going to draw them. I'll just draw another diagram. Boom, and boom. So if taking this one out of the equation, you would need, well actually both. You would need one signal to depolarize this one, and that signal again to depolarize this one. With cardiac cells, this is called an intercalated disc right here. This connects them together. That same signal can now pass through and do the exact same thing for the next one. This is important for the heart because it allows depolarization to happen across the entireties of the atrium. Now the initiator of this electrical signal for the heart, especially for the atriums, is going to be right here, called the SA node. The SA node has inherent automaticity at 100 beats per minute. You also will have another one called the AV node, but the SA node always overpowers it. It is going to be much faster. So the SA node is going to cause that signaling to happen, and through intercalated disc, it's going to allow contraction to happen downward through the atriums. This is important because it's going to squeeze the blood down into the ventricles. So once that signal has now hit here, it stops because this is a layer of electrically dead cells, except for the AV node. So if you look at an EKG, and I made it big, this, an EKG is really going to actually work downward, kind of like this. But for here, I'm just going to draw it sideways. So an EKG, all it's doing is measuring electrical signals from one prod to another. You'll put them on somebody's chest, and lead 2 is the one that I'm going to be drawing here because it's always the bedside lead. So because this is moving in direction from one to the other, there's going to be a positive inflection because the charge is moving in the direction of this one, downward. That's the P wave. That's to prove that the atriums have now contracted. Now, you're going to have a blank spot here. This is the AV nodal delay. The AV nodal delay is going to cause the atriums to be able to fully contract, get every last bit of drop of blood into those ventricles. Although 70% will already have passively filled into it, you just want allowed time for them to continue to squeeze to get every last bit of blood. Now, once the AV node is ready to fire, when it does, you're going to have this bundle of hits, which then splits that signal into your bundle branches. That will be the first jump for your QRS complex. Because again, it's moving positively because it's moving in the direction of the lead. Once it gets down to the bottom, it gets shot right back up through the Purkinje fibers. That is when this will dip down. It's negative because it's moving in the opposite direction, away from the lead. Those Purkinje fibers allow contraction of the heart to happen upward for the ventricles. While you have this squeezing downward, you're now going to have this squeezing upward. This is going to get blood out through the aorta. Really important. So that's that. And then you'll also have a T wave, which is just ventricular repolarization. So why is all of this now important? So when it comes to HFrEF and HFpEF, you're probably wondering, what is HFrEF, what is HFpEF? What does that even stand for? So HFrEF is heart failure with reduced ejection fraction. Reduced ejection fraction, all ejection fraction means is from the amount of blood that goes into my ventricles, what is the percentage of blood that is actually leaving the heart? All we care about is really the blood leaving the heart through the left ventricle because that's the oxygenated blood going to the body. So reduced ejection fraction means that 50% of the blood that gets into here is not leaving the heart. It is 50% or lower ejection fraction. This is bad because you are not getting blood out of the heart. Now, that is happening because of these cells, most of them are probably going to be dead or they're just loose. They can't contract. That is not going to have enough contraction to increase the pressure high enough to overcome the valve to allow that door to stay open long enough for adequate amount of blood to leave the heart to oxygenate the body. That is the problem with HFrEF. It is not the amount of blood that fills into the ventricle, it's the amount of blood that's actually leaving the ventricle. In the flip side, HFpEF, that is when you will actually have the ventricular wall is now extremely thick. So to draw another one, so it's a little bit easier to see, a normal left ventricle should look something like this. Normal, not super thin, normal size. This left ventricular wall will be much thicker in HFpEF. So although you're having a 50% or greater ejection fraction, the amount of blood that's able to fill into that ventricle is not enough. And when it comes to getting blood out of the heart, although you're getting everything out, it's not enough. So HFpEF is one that is actually curable. HFrEF is really not. So HFpEF, some things that you can do to cure it are either lowering your blood volume, which will allow essentially more red blood cells, more oxygenated red blood cells to be inside of this space to get ejected out. And it's going to be less water, less sodium, whatever content is also inside of your blood other than red blood cells. That's one way. And that can happen through diuretics, but I'll get more into that for topic 2. For HFpEF, you also can take beta blockers, which will lower your heart rate to allow more time to fill this space. Those are 2 ways that you can actually treat this. But as I've kind of talked about it and shown it already, the 2 ways in which you can clinically see this through imaging, the best ways are really going to be ultrasound or MRI. MRI more so than ultrasound. So MRI is where you're going to go into this massive magnetic machine and it's going to be able to, the poles, so each cell is going to then be aligned. Let me just do this. So each cell of your body is going to have kind of a positive influx to it, or not a positive influx, but it's going to have charge. In an MRI, you're going to turn, the machine's always going to be on, but those are going to now point in the direction of the magnets. Whenever you shoot a wave at one of these cells, it's going to cause it to spin. And the MRI maps the time that it takes back to get to the spot. That's how it creates its own image. So within the MRI, that's how you create the image of what's happening. You're going to be able to see just how thick this left ventricular wall is. Obviously, the thinner it is probably going to be HFrEF. The thicker it is going to be HFpEF. That is a great way of being able to use this imaging to see how this is able to be diagnosed. Ultrasound, it can do the same thing, but it is much harder to see because ultrasound is going to be shooting, let's see if I can draw it. It's going to be shooting waves down into your body, and it's going to be tracking those waves getting refracted off of dense objects. Bone is extremely dense, especially or not dense in the middle, but the outside of bone is going to be very hard. So this wave is going to get bounced back off the outside of bone. So it'll be hollow, or it won't pass through. This is bad because of your rib cage. You're not really going to be able to see the heart in multiple different views. you're only going to be able to see it in one direction by sticking the ultrasound almost underneath the rib cage and pointing it upward. But that is just the different imaging ways in which you can see HFrEF and HFpEF. So now, topic 2. Topic 2, and I'm just going to read it, is using Wigger's diagram, explain to me how we can relate depolarization, muscle contraction, and pressure changes to each other. Be sure to include in your discussion how this may be affected by atherosclerosis and how pharmaceutical drugs can be used to help in this disease treatment. Now, a lot of what I talked about for the last topic is also applicable here. So I'm first going to talk about Wigger's diagram. So Wigger's diagram, this x-axis is going to be time. Now you're going to have multiple different things on the exact same graph. So you're going to have this, boom, here, down, boom. But you're also going to have blood volume, boom, boom, and then kind of slowly filling back up, as well as a here, here, and there. Okay, so this is a poor drawing, but this is the best way I can visualize it. So this will actually be together, like the exact same. Okay, so this bottom line, this is relation to blood volume. This line here, this will be blood pressure. This top line here is aortic pressure, AKA the back pressure that is on the aortic valve. Now, when it comes to talking about depolarization, muscular contraction, and how can we see it and how can we prove it on Wigger's diagram, everything will be proven in here. So this will be the P wave. We know this because just as I talked about, when you squeeze the atrium, when you're squeezing and getting that blood out of the atrium, you will see pressure increase, because just like if you're holding a juice box and you squeeze it as hard as you can, that pressure inside of it is going to increase because you're decreasing the size of the container. So volume is going to decrease, but pressure increases. So that's why it goes up. But also the blood volume, the juice inside of the juice box, it is now exiting, it's leaving, it's going through that valve into the ventricle. So that's why the volume will decrease during this contraction. That is proven there. That is one way how you can prove muscular contraction, depolarization, and pressure changes to one another. Another way how you can prove all of this is here. So this is the back pressure on the aorta, or the aortic valve. Whenever you squeeze the ventricles, it is going to increase in pressure. It's going to increase. But the second that it hits the pressure and starts to exceed the back pressure of the aortic valve, now blood is going to start leaving the ventricles, as you can see. Once this pressure starts to no longer be exceeded of the back pressure, that valve is going to close. So that's what happens here. Now pressure is going to drop because that valve is closed, and you also have no more volume inside of the ventricle because you've squeezed it out. So that is ways in which you can prove on Wigger's that you have muscular contraction, depolarization, as well as pressure changes. So, atherosclerosis. Atherosclerosis, all it is clogging of arteries. So if a normal artery looks like this, allowing blood to flow through, atherosclerosis is going to have a hump there. That is a blockage of your artery. Now, atherosclerosis can have an impact on Wiggers, and I'm going to just draw the graph again so I can see it. Okay. So with Wiggers, atherosclerosis is going to cause an increase in the aortic pressure, because now if you're having a blockage of this artery, all of this blood is not going to be able to pass through this fast enough. So you're going to have a massive increase of pressure here, which is pressing back onto the valve. So now this pressure is going to be much higher, or your ventricles are going to have to exceed a much higher pressure in order to open up that door. I always think about it as somebody trying to push it, you're trying to push somebody away from a door. You have to exceed the pressure that they are. That is the problem with atherosclerosis. It's going to cause Wiggers to now get shifted upward because you're going to have massive pressure increases. You're also going to have a problem with blood volume because this is going to get squeezed inward, since you're not going to be able to exceed that back pressure for very long. So not only will Wiggers get shifted up, it's going to get shifted more narrow. Now, atherosclerosis. There are different ways in which you can treat this. The first way is kind of what I talked about earlier, is diuretics. So diuretics are going to cause you to lower your blood volume by making your blood more actual red blood cells. You're going to lower any concentration inside of your blood that you can actually urinate out. You're going to no longer have a high retention to certain things. So now, filling inside of the heart, you're going to have more pure blood, but you're also going to have less blood or less content that's creating back pressure on the aortic valve. That's going to cause the pressure to now go back down. It's not going to be as high. It's going to just make things a lot better. Another cure, or another thing that you can do through pharmaceutical drugs, is calcium channel blockers. So calcium channel blockers are essentially going to lower your heart rate, which is going to allow more time for filling into the heart, which is going to allow for a greater contraction, increasing the pressure of blood going out of the heart. So you're going to exceed that back pressure. It's just going to slow things down, and it's going to allow things to happen a lot more smoother and lower that pressure. So another cure that is a bonus that I want to talk about is actually some surgical methods in which you can go and treat this. So atherosclerosis, it's really caused by foam cells being underneath here. So one surgical way that you can go is angioplasty. So you're going to feed a wire that has a balloon on the end of it all the way through to this point and stick the balloon between this point. You're then going to blow up the balloon, which will press all this stuff back down, and then you'll take the balloon out. This is not a permanent solution. It's very temporary because this will eventually fill right back up and it's going to start clogging again. Now, a stent will do almost the exact same thing as an angioplasty. It's just a permanent solution. So now you'll actually have something that will permanently stay here, allowing blood to flow through it. Now, a stent will not be attacked by your body because it is laced with drugs that will not cause inflammation, and it's going to cause it to not get attacked by your white blood cells. And it will permanently stay there. It's almost like a tunnel. It is concrete that is pressing against the dirt, allowing people or blood to flow through it. The final way in which you can treat this surgically is by bypass surgery. So you're still going to have that bump here, but they're going to go and harvest. Typically, one of the main ones, they're going to harvest a vein from your leg, which is your great saphenous vein. They're then going to attach pieces of it, depending on how many bypass you're doing, before and after that blockage to allow blood to take alternative routes. That would be an example of a single bypass. If you do it again, now that's a double bypass, and so on. Those are different ways in which you can treat this, and yeah.